This lecture is going to be about the many steps we need to take to prepare for surgery. As you are learning in lab, there are many steps to prepare for surgery, and really going through your checklist methodically is going to be really important so that you stay prepared for everything. And we're going to take you through that checklist today. The history, which we've talked about before, is a really important part of our checklist for surgical preparation. We need to ask them really specific questions and get some information. If they're getting dropped off by their owners, you need to ask it then. There are some animals that may already be hospitalized that you need to call and ask some of these questions of the owners either way. If they're just dropping off, obviously when they were last fed, we need to know when they last ate, what might be in their stomach, if there are any medications that they're on, and when they were last given. And these medications should include nutraceuticals and supplements the owner may not consider medications, if the pet has any allergies, and certainly any medical conditions or other recent illnesses. You'd be surprised as you're out there in practice that there are owners who actually take their animals to different vets depending on pricing, depending on if they're summer somewhere else and winter somewhere else. So it is really important, even though you may have a medical history in their chart, but you need to make sure that there's nothing besides that. Also, if the owner has treated anything on their own, we all know that people get on the internet a lot these days, and there's a lot of recommendations and information that's out there that people may be doing on their own, including supplements and nutraceuticals. So we need to make sure that we are asking if there's anything else that the pet may be receiving. We want to be sure to use open-ended questions and not lead our owners to answers that they may think that we want to hear. So instead of saying something like, you don't feed your dog anything but dog food, right? And of course an owner is going to be like, oh geez, well, I gave him my pizza last night, but I shouldn't have done that. So yes, they just eat dog food. So then you need to ask a question like, what does your dog eat? And certainly you can open it up further depending on the answers that you get. When you're talking with the owner at drop-off, or if you're calling them on the phone if the patient is already hospitalized, this pre-surgical communication needs to go just beyond those historical questions that we were just talking about. We need to confirm what procedure is going to be performed and what exactly is going to be done, so that the owner is well aware and that you confirm what the owner thinks. There are just kind of horror stories out there about wrong limbs being removed, and this happens in human medicine too. It certainly can happen in veterinary medicine, and you do not want to be a part of that. So if it's an amputation, what limb is it? If it's a mass, what mass is it? Which ones? How many? You want to get really specific. And if there's any confusion, you certainly want to bring the veterinarian into the conversation. This next question, does the owner wish to be called with any change in plan? My position is that the owner should absolutely be called with any change in plan. So you need to be sure that you have a number for the client where they will be during the procedure, and you need to make sure they know that. In case of an emergency, if anything changes, what number can I call? You can, though, establish that if there is a change in plan, that the doctor will use their discretion to make the correct decision, which owners certainly need to understand if we can't get in touch with them. You need to write all of this information down. If it is not in the file, it is like it never happened. So you need to write all of this information down. Owner understands that the left rear limb will be removed. Confirm with the owner which masses, and you can take a Sharpie and circle them. You can lots of times. What I like to do is actually take a little, shave a little spot. If there are multiple masses, just shave it, because you're going to have to clip anyway. Just go ahead and do that if it's a really fuzzy dog, especially. So we want to get all of that information into their file. And again, we need their contact information, where they will be during the surgery, so that we can contact them at any point. The consent form, which is going to contain a lot of this information that we communicated with the client pre-surgically, is part of the medical record. It will be signed by the owner, and depending on what the consent form looks like, should have a lot of specifics on it that you went through, and then anything additionally needs to be written in the file in some sort of, in the medical record, as some sort of part of client communication. It will have both surgical and anesthesia consent, so consent for the surgery and specifically what procedure is going to be done, and then also for the anesthesia. It's going to have cost estimates in there that you are going to have to follow when you, depending unless plans change, but certainly the owners need to see that and verify that they understand that. And also you're going to, depending on the situation, but even for a healthy spay and neuter, you have to have some sort of information in there that there could be an emergency situation and what the owners want the veterinary team to do at that point. The resuscitation consent is just tells us how far the owner wants us to go if there is cardiopulmonary arrest. Again, with a young, healthy patient, as a spay and neuter, obviously we're going to do everything that we possibly can, and we should tell the owners that that's what would be recommended. But this can really change as patients get older, as they have confounding illnesses that can be an issue also. And that there are times where you could say you go in for a there's some mass in the abdomen, and you get in there and you see that really it is spread everywhere. You can see metastasis, that maybe at that point the kindest thing to do would be to euthanize the patient. All of this needs to be frankly discussed and very clearly written and signed for as part of the medical record. The physical exam is extremely important pre-surgically. It is going to help us decide whether this patient is healthy enough to undergo anesthesia. We're going to evaluate them systemically. We're going to evaluate any comorbidities that may be making anesthesia a bit more questionable, but they may need the procedure. So we are going to make some big decisions based on this physical exam. Obviously, we're going to get temperature, pulse, and respiration, paying particular attention to any heart murmurs or arrhythmias, any respiratory disease. Obviously, all of those are really critical to our anesthetic protocols. And then a full physical exam, you want to be sure you're doing it the same way every time so you don't miss anything. I'll show you how I do mine, but you're going to develop your own routine of how you work through physical exam so that you see and pay attention to every aspect of it. So you would be surprised the number of things that we can find on a physical examination that can tell us that there could be significant issues with anesthesia and potentially the surgery. Some examples include dehydration. You're going to be able to see that if you tent the skin up and they have that skin turgor. If they're dehydrated, they can have big issues with hypotension under anesthesia. And then we can end up with long-term issues such as kidney damage if we're not perfusing those organs the way that they should be. It can end up having implications down the road also. We can see anemia if we look at the gums. Mucous membranes can be pale. If we don't have enough red blood cells, we might not be able to oxygenate the way we need to, especially during anesthesia. If you look at the skin, for example, this picture, those petechia on this dog's belly, they look like little hemorrhages kind of all over the place, or they can have bigger bruising. We also need to look at the mucous membranes for that. We can actually see signs of a clotting disorder. Now, obviously, we would also be running blood work that could help confirm this. We always want to check to make sure both testicles are there before a neuter, because a retained testicle is going to completely change the surgical approach. That may change it from a quick skin incision into an abdominal surgery. And so these are all just examples of things that we can find and how important it is to do a thorough physical examination. We're going to work through some of the more of the specifics with the physical exam that you need to be looking for, but again, you want to be moving through your physical exam really methodically. Body condition score is a big part of the physical examination, usually graded on a scale from 1 to 9 or 1 to 5, 1 being emaciated, 9 being obese. In terms of anesthetic implications, if there isn't much body fat, so if they're between 3 to even 1, obviously, they're going to be way more sensitive to anesthetics. Not much fat, which can help absorb some of the, or slow down some of the drugs that we give the animals, depending on the medication. Obese patients may have issues with cardiovascular function. They actually may not be able to move the air as well, and certainly can become kind of high anesthetic risk because of that. Hydration is another important thing we talked about before that really can play a key role in how we need to help them during anesthesia, or if they're even an anesthetic candidate. So again, we're going to look at skin turgor. You can kind of grab tent the skin over their shoulders and see how quickly it bounces back. The eye position, sunken eyes, can be an indication of dehydration. Capillary refill time can be slowed with dehydration, and also the heart rate and pulse strength can be affected. So we want to look at all of those things. Mentation is going to be important because certainly neurologically we want our patients to be as stable as possible undergoing anesthesia. This can be an assessment of brain function. The mentation is just how the patient is and responds to stimuli and how easily it can be aroused. So normal healthy patients, we call them BAR, right? Bright, alert, responsive. They are kind of engaged with what's going around them. They would notice if a noise, somebody drops something, they're going to kind of pay attention to that. They may be a little curious. They may be scared and nervous, but still bright and alert and responsive. Healthy patients can also actually be quiet, alert, and responsive, not as engaged, and depending on how, feral cats, I think of kittens that haven't been exposed to humans lots of times, can be a little quieter, but still alert and responsive. Lethargic is a state where they are certainly more sleepy in that sense. There's a mild decrease in consciousness, but we can get them up. So they're lethargic, they seem tired, they seem kind of blah, but they can be easily aroused. Obtunded is moving down the scale where they appear depressed. It's not really a word we can use in our veterinary patients, but they seem very tired, and you're not able to fully arouse them. They just aren't responding to stimuli the way that we think they should. Stuporous is that they are really in a sleep-like state. They're very depressed to a point where they're not really responding, but you can arouse them with a painful stimuli. So if you take those hemostats or your fingers and really pinch on those toes, you're going to get them to react in some way, but then they're going to probably go right back to their stuporous state. Comatose, as you probably know, they cannot be aroused. They are unresponsive to any stimuli. So we grade all of our patients on this. Certainly anybody undergoing anesthesia, we don't want them to be even obtunded or beyond. Lethargic, it kind of depends on what's going on and what surgery you're about to perform. So some helpful hints for evaluating the cardiovascular system during your examination. You want to kind of focus on three major things: the heart rate, the heart rhythm, and murmurs, if there are any, hopefully not. The heart rate you can get from auscultating with your stethoscope, or certainly you can use pulses for that. You can really get good. You want to be able to do both, go in between, because sometimes you'll have your stethoscope and that'll be the best way. Sometimes you'll just want to grab a pulse and do that. The best place to get a heart rate is to auscultate over the left chest wall. That's where it's going to be loudest. That apex of the heart is going to be there and a little closer to that left side, so you should get your best listen there. Again, practice this and move your stethoscope around in here where on a nice relaxed dog or cat at home, kind of where you're hearing it best, and that can give you a good idea. That apex, if you bring their elbow up, sometimes up to their chest, that's about the area where the apex is. If they're obese, it may be a little more difficult. Again, finding that apex is going to be the key to that. If they're panting, that can also make it difficult to get a heart rate and hear their heart for the other things you need to evaluate. What I like my technicians to do is just gently kind of hold the muzzle closed, and so I can at least get a few seconds without them panting to hear that heart. And this can be helpful with rhythm and murmurs also. Sometimes they're panting strong enough that they need a break, and so you need to kind of let them pant for a little bit, then try it again. Sometimes they're panting through the closing of their mouth, but hopefully it'll make it a little bit quieter. Certainly don't stress out the patient, so you want to just do it gently, and you want to keep giving them a chance to pant depending on the reason for it. Purring can also cause difficulties in listening to the heart. There are a couple things you can do. Cats often don't like water, so if you run the faucet kind of loud, that can stop their purring at least briefly. Same with a little alcohol swab near their nose. They don't like the smell of that, so they may stop purring again briefly. You can also very gently and for only a second or two just kind of pinch their nose shut a little bit, just not so they can't breathe, but just kind of annoys them enough that they may start. Occasionally they're purring so much and you can't do anything, and they're just super happy cats, which is awesome, but you want to do something like take a temperature, and that's going to stop their heart, their purring most of the time. Every once in a while not, but you want to also recognize that their heart rate is going to increase during those things, so as much as we can avoid doing it around the time of other stressful things going on as possible would be great. When we're evaluating heart rhythm, we obviously like to hear a normal sinus rhythm, which is just a regular lub-dub. It's very strong. When you're feeling pulses, which I always like to do when I'm listening to the heart, those pulses are nice and synchronous with the lub-dubs. A sinus arrhythmia can be normal in a patient. We've talked about this previously, and you'll probably hear this in lab. During inspiration, that heart rate is going to increase a little bit and then decrease during expiration. And again, this can happen in normal animals, but you do want to evaluate that the pulse is beating at the same time as the lub-dubs. Anything else you come across, you certainly want to report to the veterinarian and kind of stop everything to make sure that they are clear. Murmurs, it's really important to listen to both sides of the chest. There are certain murmurs, for example, dilated cardiomyopathy in big dogs. Sometimes we only hear it on the right side. So if you're only auscultating the left side, you actually may not hear that, and that would be a big problem. The murmurs sound like kind of whooshing. It's really a whooshing between the lub-dubs. And if you haven't heard one, obviously anytime you hear anybody say, oh, I hear this arrhythmia, or I hear this murmur, grab your stethoscope and put it up to the animal, because you want to listen to as much as you can and learn from them, because that's how you're going to pick those things up. Definitely watch the videos always before lab, Watch everything that is on Vanco Hall. Watch it for class 2. There are some good ones there, so don't miss them. I talked about the importance of the pulse palpation when you're also listening to the heart and evaluating the rate and rhythm. So again, these should be strong and synchronous with the heart rate. The femoral artery is kind of my go-to. It's really the easiest to find. When you're sitting at home with your animals, definitely, it's funny, ever since vet school, if I'm just sitting next to a dog or a cat, I just reach for their femoral artery. I don't know why. It's just something I do, and I bet you will start doing it too if you're practicing the way you should. You can also palpate metatarsal and metacarpal arteries right on the tops of their feet in bigger dogs. But certainly the femoral artery is usually pretty easy to get to. And again, it can kind of give you an estimate of the blood pressure. You want to feel these, and if you're not feeling them, that can be a major indication of some issues. Mucous membrane color and capillary refall time are also important in our cardiovascular examination to tell us about perfusion and other things too, such as anemia. So again, another really important aspect of that cardiovascular exam. The respiratory system is sometimes challenging for students to evaluate. You certainly want to spend some time with your stethoscope and listening to lungs along with the heart. So you're going to kind of move away from that heart into the different lung fields to evaluate the lungs. And you want to see the rate and the character. So by rate, obviously, we're just talking respirations per minute. And the character is just kind of the quality of it. Are they having a hard time breathing, or does it appear that way? Do you hear anything? Stressed animals certainly can hear a little more. If they're panting or purring, certainly you hear a lot. And what we need to do is kind of separate all those things. Another biggie that we see a lot, especially in lab, is cats with upper respiratory issues. So you're actually going to hear some referred upper airway congestion down in their lungs, and you got to separate all that out, which can be a challenge. Abdominal palpation, which is what this picture is showing, just to make sure there's nothing else in there. We never want to go into surgery and be surprised by something that we could have picked up on physical examination. So always want to check that out, make sure they're non-painful and anything that feels out of the ordinary. Again, this all comes with doing this constantly. So practice, feel every abdomen you can get your hands on, and you'll start to learn normal from abnormal doing that. We're going to go through some of the blood work that we need to have done before anesthesia, but then also we obviously need to mention that if there's any concern, and depending on how old the patient is and what surgery we're doing, we can add more onto this list. But this is what we call a minimum database, which just means that this is the minimum amount of things we want to do before surgery. Lots of blood machines and companies, depending on if you send out your pre-anesthetic blood work or if you run it in-house, they have a pre-anesthetic panel, so that can make things more economical for our owners and kind of just limit what we want to look for in our minimum database, and then can add more on depending on the results. We're going to go through each of these. So I know most of these things, again, we've been through, but it's really important to understand and to know what we need to look at. And obviously one of the big ones is our packed cell volume, also called the hematocrit. This is these number of red blood cells. It's going to tell us our oxygen carrying capacity of the blood, which is important all the time, and especially when a body may be stressed under anesthesia. A low packed cell volume is called an anemia. Again, this can occur because of decreased red blood cell production, as in chronic diseases like chronic renal failure, decreased red blood cell lifespan with things like autoimmune disorders, immune-mediated hemolytic anemia. We actually see relatively regularly in animals. That can decrease their lifespan. Parasite infections can also do the same. And we can get anemia from blood loss. So if there's trauma, any kind of clotting disorder, even gastric ulcers that they can just bleed little bits from can cause anemia long term. If you have a high PCV, that's usually a result of dehydration. There are some other conditions that can do that. And we'll see a high PCV with hemorrhagic gastroenteritis cases, and these guys are very sick, but it's one of the hallmarks of it is we're going to see a PCV that is elevated. Total solids will be measured at the same time as the PCV. It's going to, again, be measuring the plasma proteins, the albumin, globulin, and fibrinogen that are travel through the blood also. These proteins are what provide the oncotic pressure in our vascular system. So that's what keeps fluid in the vasculature and keeps it from leaking out to the tissues. And so that oncotic pressure is really important. If we have a decrease in these plasma proteins, so a decrease in total solids, our fluid can leak out of the vasculature into surrounding tissues, and obviously leaves us with issues kind of on both ends. A high total solids is usually a result, again, of dehydration. It can occur in certain neoplasias like lymphosarcoma and certain infections also. A low total solids can happen because we're not producing some of these plasma proteins. For example, albumin produced in the liver. If we have liver disease, it'll have decreased production. If they're not taking in adequate protein, that will be important. And if they are losing protein through diseases such as renal disease, where they are urinated out through the kidneys when they shouldn't be, it can happen because of blood loss, and also parasites and GI diseases where they're actually not absorbing proteins the way they should. Barbiturates move through the blood highly bound to these proteins. So if there aren't as many of these proteins, if the total solid is low, there's going to be more free drug in the plasma, and you may need to have an increased dose to get the same results. Blood glucose is the result of carbohydrate metabolism. It's also an endocrine function. So obviously this is important in overall health for these animals. It can be increased by stress. We can see cats up really high. I mean, greater than 150, even up to 300. I don't always get super excited, depending on how the cat is acting. Certainly if the cat is completely mellow and it's elevated like that, then that is not normal. If we have a diabetic animal going under anesthesia, we need to definitely be checking their blood glucose during anesthesia to make sure it's not going too low, especially if they've been given insulin. We may need to supplement, or certainly too high where they would need insulin. Neonates, just because they're so little and they're kind of burning through their carbohydrates, may need supplemental dextrose also. So we want to check that depending on their size and what kind of breeds they are. There are some dogs who are a little bit older, like Yorkie, who may not be neonates but can be a little older, that would still be prone to low blood glucose. So you always want to make sure you're keeping an eye on that. And you can do spot BGs anytime during anesthesia. The blood urea nitrogen is a product of amino acid breakdown in the liver and normally is removed by the kidney. So it is a good measure of kidney function. If it's elevated, it can get elevated because of dehydration, so it is higher because we don't have as much fluid in our vasculature, but it also can be an indication of kidney failure. Then we want to start investigating other aspects of our blood work that can tell us more about kidney failure. If it's a low BUN, that's a sign that we may not be getting the protein that the animal needs via starvation or adequate protein in the diet. The alanine aminotransferase, or ALT, is a lot easier to say. Again, this is a liver enzyme, and we're going to see it elevated if there's liver damage that is important because our liver, along with our kidneys, is what, but our liver specifically is metabolizing a lot of our drugs, kidneys excreting a lot of our drugs. And so if these things aren't working properly, then certainly their ability to handle some of these anesthetic medications is going to be severely compromised. So we want to make sure we have an idea about how they're functioning. Certain drugs can also elevate the ALT. You would know this from the history that they were on phenobarbital because they have a seizure disorder, or they're on corticosteroids for multiple reasons, and that may be the cause of the ALT. That may also signify, though, that our liver does have some issues, so we need to be really careful with our anesthetic protocol. So the anesthetic protocol will ultimately be chosen by the veterinarian, but certainly the technician plays a big role in helping us figure out what's the best thing for this patient. So obviously there are lots of different factors that we're going to look at when we're choosing what we're going to use as our anesthesia. If there are any issues with the animal, if they're dehydrated or they're anemic, we obviously want to correct any of those things that are correctable before anesthesia. Now, sometimes that's not possible, but if it is at all, we want to hydrate them, and we want to figure out why they're anemic and fix that if it's fixable before we jump into anesthesia. Other things that can influence what we're going to do, obviously it depends on what you have available at your facility. So some facilities only carry certain drugs, they only have certain equipment, and you're limited in terms of what's available in terms of what you can give them, but also how you can handle them depending on what you give them. Certainly veterinarians are more familiar with certain medications and they like certain medications, or they've had a bad experience with one medication. I talked about xylazine with my dog Clover, who had some issues with it. I don't use xylazine. There's no reason to not use xylazine because my dog had an issue with it, but certainly I don't reach for it. The procedure has a big impact on that, depending if you're doing a long procedure or what kind of pain medications you need, or if it's quick, if it's not opening the abdomen or opening the chest. So all those, that plays into it. Cost is huge. We can't ignore that. It's usually in clinics. You kind of have to pick the drugs as your protocol, and it can go up depending on what drugs you choose, which may affect whether a client is going to okay a surgery or not. And again, how urgent is the surgery? Are we going to need to get them in to surgery before we have time to sit and wait 15-20 minutes for those pre-meds to kick in? Do they have other things going on, but we can't worry about their diabetes because they were hit by a car? We need to place a chest tube. These are things that you're going to have to choose the best drugs and protocol that you have available for the situation. There's some pre-induction patient care that we need to talk about, and one is the question of stabilization. There are some animals who are really sick or injured, for example, hit by a car, that can't be rushed to surgery. And so if you think of hit by a car and they've fractured their pelvis, but they also have a pneumothorax, obviously we have to stabilize and assess and respond to the pneumothorax first, and then the fractures can wait. And you'll learn, especially with those emergencies, what things are okay to kind of sit back and deal with the other issues and get patients stabilized, and what we can't. For example, if we have an animal with that bloats and has a GDV, even though they are compromised in many ways, we cannot wait for them to get stabilized and get them all the meds that they need to get, and see what else, blood pressure we can take care of. We need to get them to surgery right away. So we may need to do things really fast. For example, the GDV, we want to decompress their stomachs before we get them to anesthesia. If we need to tap their chest or abdomen to remove fluid or whatever might be going on there. If we need to get them on IV fluids and get them out of shock, get them hydrated, and if we need to get pain medications on board. So again, all of these things depend on the specific situation and the specific animal as to what we're going to do before we jump into getting them under anesthesia. Fasting our patients is something that obviously we do on a regular basis when we tell our patients to not have any breakfast that morning, no food after 10 o'clock or midnight or whatever your practice says, is going to be important for a couple of reasons. If there is food in the stomach, obviously you can get reflux into the esophagus that can cause issues. When we put them under anesthesia, that swallowing reflex is gone, and we talked about that. We were talking about our reflexes with our assessing anesthetic depth. So if they're having this reflux, that because they've got a lot of food in their tummy, and then we make them sleepy and slow all their GI stuff down, they can actually end up with aspirating some of the stomach contents into their lungs, because again, they're not going to swallow it down, and their reflexes are not working, so any kind of food or stomach juices can kind of go right down the trachea. They can end up with esophagitis, which severe enough can actually cause a stricture, which is a major issue. So longer term issues can happen. Vomiting happens in our conscious patients. As you guys probably know, that is active expulsion of stomach contents. So they do the herka and it comes up and they're working hard at it. But regurgitation is a passive process. It just comes up without the patient having to actively expose those stomach contents. And so this can occur in our unconscious patient. If we withhold food, depending on the age and the size of the patient, for 8 to 12 hours, we can decrease this regurgitation from happening. In really small animals, or if they're critically ill, we can't fast them necessarily for 8 to 12 hours. And that, again, these are individual situations, and you're going to talk to the clients and tell them when they're going to want to eat. Also, really species dependent too, on what animals you are putting under anesthesia. You can use an antiemetic in unfasted patients to empty their stomach contents, so to get them to throw up. Might be something that you consider doing. You can also just reschedule the surgery if it's an elective surgery. So again, it all comes down to the specific situation. Intravenous catheterization is one of the most important, and I think one of the most fun things that veterinary technicians get to do. And I often push my techs out of the way so I get a chance to do them, because I tell you, I'd put in catheters all day long if I could. Lots of reasons to put in catheters. It's a way to give them drugs, right? So we can give them their induction drugs, but we can also give them any emergency drugs they might need, so having that port and access to the vein is super important. We can give them fluids during anesthesia so they can keep their blood pressure maintained. This is going to help perfuse our vital organs, kidneys, liver. Again, that's going to prevent longer term damage and keep everything a lot healthier. It gives us access to give constant rate infusions of different medications, whether it's anesthesia. For example, you may just be using propofol to keep them under anesthesia. Any analgesics. There are a lot of ways that we can give these medications for pain relief that just go constantly in a slow drip into their vein. And obviously, again, fluids containing electrolytes and more. There are several anesthetic agents that can actually cause a lot of damage perivascularly, that they're vesicants, so it just kind of does bad things to the tissue if it's given outside of the vein. So with those, obviously, there's no other way to give it but intravenously, and you have to make sure that you have a really well-placed and patent catheter. You can have drugs that you can't usually give together, but you can give them to the vein pretty quickly, one right after each another. So it's a way to do that without putting them in the same syringe. You can give one right after the other. In your textbook on page 58, there's some good information on IV catheterization. There are a couple different types of catheters. There are catheters we put in peripheral veins, and this is most commonly done, especially if we're using them for short term or just a day procedure. Again, great for induction of anesthesia, and we're just going in, spays, neuters, and even more complex surgeries where they're not going to necessarily be in the hospital long term. A jugular catheter, and this is a picture, you can tell, of a dog's neck, the nose is pointing towards the left. This is what we call a central line. We're going to put these in if they're going to stay in for a little longer than 3 days. Obviously, they need to be under 24/7 supervision, so really in any hospitals where you don't have 24-hour care, they're probably not going to be used. We'll still use, even for longer term use, we'll still use the peripheral catheters. You can also do some really excellent systemic monitoring of blood gases and different things. You can draw blood from these guys, and very useful. The most common sites that we are going to place these peripheral catheters in the canine is the cephalic or lateral saphenous veins. Feline cephalic, medial saphenous veins, you can put them in femoral veins. Becomes a little tougher as the animals get smaller with those back legs. You're going to need to, every time, just like every checklist that you can make, you want to include these supplies for your catheter, and you want to come in having all those supplies set. Don't even start the process unless you make sure you have it all. And you'll see us every once in a while, we'll forget some part of it, and you get really frustrated with yourself. So you want to be sure you have catheter, never just one catheter, always grab a couple. Sometimes you want to grab a couple different sizes because you may decide right then and there to change the size that you're going to use. You want some kind of cap on it, so either an injection cap, or you want your T-port, or some kind of fluid administration set that you're going to hook up to that. If you're just trying to get it in fast, just put the injection cap on. You can always change that out. An extension set is going to give you that extra space that you might need depending on where the animal is going to go, how long the catheter is going to be in. You want your tape all set and prepped, your materials to scrub and clip, your flush, and your materials to bandage and cover up that catheter site. So your catheter choice is going to be determined by where you're going to place it and what it's used for. So again, going back to if it's going to be long-term and you're working in a facility that can monitor them, the jugular catheters are great. Otherwise, you're going to decide if it's going to be a really short procedure or if they're going to be in the hospital for a few days and need to have it sustained for longer. There are a few different kinds of catheters. There's the over-the-needle catheter. I'll show you pictures on the next slide. Those are short-term, really surgical catheters for induction and fluids that we might need to give them. Through the needles are the ones going into the jugular, and so those are patients that are sick in the intensive care unit and need some special care that can require long-term fluids, but other things that may need to be done that we can use the jugular catheter for. There are also butterfly catheters. And this is just if you just need that one-time access outpatient. You're not placing it in. They're not staying for the day even. We use them for blood draws in cats, I know, but you can also tape them down and administer anesthesia through them, such as propofol, for shorter surgeries. I would always recommend going with an over the needle for anything that's going to last too long, though, because those can get pulled out pretty easily. So not one that I would necessarily recommend for anesthesia. The size, you have different gauges depending on how big the patient is and the vein. You can always assume the veins are actually pretty big, but the bigger that gauge is, sometimes can be easier to get through skin depending on the animal and how delicate their skin is. And the length also depends on the patient's size and what vein you're choosing and where you're choosing to place it. So these are our 3 different kinds of catheters. The upper left-hand corner is the over the needle. You can actually see the needle poking through the catheter itself. We're going to insert the whole thing and then remove that needle, and the catheter will remain in the vein. The bottom left-hand corner is our butterfly catheter, and then the right-hand side is one of our through the needle or jugular catheters. So again, like we said, we're going to choose whatever capping a piece of equipment that is best for our situation. A lot of the times we may just need an injection cap. This is just if we're doing occasional injections, good for inducing for anesthesia, that it's not going to leak back out. They're very cool. Obviously, if you use them over and over and over and over and over again with large bore gauge needles, they may start leaking at some point, but they're pretty awesome. Our T-ports is what's on the right-hand side, and that it's a nice way to be able to connect with fluids. You still want access through that injection cap at the top, which is still there, but it allows a little more flexibility when we're going to hook them up to different other lines. We're going to grab an administration set to give our fluids, and depending on the size of our patient, if they're less than 7 kilograms, or our small patients, we're going to use a 60 drops per mil administration set. If they're greater than 7 kilograms, we're going to use our 15 to 20 drops per mil, and this is for safety purposes that we choose these 2 different types, so you want to be sure to use the right one. The extension sets are going to be helpful to get between the catheter and the administration set, because depending on where you get them, they're at different lengths, and you might need your fluid pump maybe a little further away than from the cage than your patients or from the surgery table. So it gives you a little more flexibility in where you can have the patients. So everybody has their own opinion about tape. Tape is what secures the catheter to the patient. We used to have a lot of discussion about this in practice, which was the right way to tape in a catheter. And ultimately, if the catheter stays in and you can have access to it, then you've probably taped it in the right way. If it's too loose, the catheter can easily kind of pull out a little bit and kink. It's not going to be useful. And that is very frustrating. If it's too tight, sometimes you can't actually inject into it. It can occlude the blood. There are patients where it can be really hard to get in a catheter. So if you mess up the taping, that can lead to some pretty serious frustration on a lot of people's part. So finding a good way to tape the catheter to the patient is really important. I have what I think is an amazing way to tape a catheter in, and I rarely have issues with the catheters coming out because of the tape. So I'm happy to show you that. You'll obviously learn different ones in lab, but just be sure that those catheters don't come out, and that, again, that you can access them, and if you needed to replace part of, your patient may chew out the T-set, and if you don't have it taped in a good way, You may not be able to get in there to replace just that T-set, and you may cause issues. So think about all of that when you start to develop your procedure for taping in. Other materials that you need, you want to use a number 40 blade on those clippers. You want to get close to that skin. That's just like our surgical prep, which we'll talk about. You need surgical scrub and alcohol that you're going to do in a specific manner. And then you want to have your fluids ready, or heparinized saline. You're going to flush that catheter after placement, and if you use the heparinized saline, it can prevent clots. In lab, we don't usually use heparinized saline because it's so short term, but certainly if they're going to be using it for a little bit, it's important to routinely flush at least a couple times a day with hep saline, and that's part of your catheter care. You definitely want to bandage them if they're going to be in the hospital for a couple days, or they're leaving the bandage in, or they're leaving the catheter in while they're going home. So you want to be sure that you, again, learn to bandage it in so that you can access it so it doesn't cause swelling of the limb distal to the catheter, which is a really common problem when we're trying to maintain catheters. And again, there are some really good ways to do that, and I'm happy to help show you what I think works really well in lab. Last thing about jugular catheters, again, used for critically ill animals. These are really great. They're fun to place if you get to work in a hospital where they do them, and they're super helpful if you have an animal who's in the hospital for a long time. You can collect blood from them, which is great if you have to do it regularly, because you certainly don't want to be poking that animal all the time. If you have to give lots of meds, it can actually have multiple ports for doing that, separate from collecting blood. You can also measure central venous pressure, which is how effectively the heart is pumping that blood around, because it's that jugular, right, is going right in down into the heart. So this can be important when we're trying to monitor patients which are in heart failure, or if we need to keep a really close eye on their hydration status, that we're not overhydrating them.
Hi, I'm Megan. Today we're going to place an IV catheter in a dog. I'm going to get started with all of my equipment. First, I'm going to tear some tape. We're pretty particular about the way we tear tape for our IV catheters, just so that we know what to expect if we ever need to remove tape and replace it. So the first piece, I'm going to start by tearing about 1/2 inch to 1 inch down and wrapping one tab around so it looks like this. This tab is what's going to slide under the catheter in this first piece of tape, and it'll wrap around the leg. Second piece of tape, just make a little notch in it. This is also going to slide underneath the hub and wrap around the leg. Third piece of tape is what's going to secure the T-port to the leg. I like to make little tabs at the end so it's easy to remove. And then the last piece will be to make a tension loop with our fluid line extension set. So I've got my tape here ready to go. I'm going to prepare my scrub. So I'm going to use chlorhexidine scrub. I prefer cotton balls, and also some alcohol. So that's ready to go. I like having some dry gauze in case we get a little bleeding around. We want to make sure the leg is clean, the tape stays clean. I also have a selection of IV catheters, a T-port that's been flushed with heparinized saline, a male adapter plug, and now I'm ready to go. I've got my catheter picked out. In this size dog, 18 gauge catheter is a good choice, so I've got one of those. All of my tape is torn, my scrub is ready. So I'm going to get started by clipping a nice rectangle of hair over the cephalic vein. Clear all these little hairs out of the way. It's really easy on this dog to see this kind of accessory vein that runs down along the side there. That is not a good choice to place an IV catheter. The problem being is a lot of times your catheter is going to come out right there. Here's her carpus, there's your catheter. You're going to have all this tape down here. It's going to be on the lateral aspect of her leg. It's probably going to clot easily. It's going to, your fluid pump's going to give you problems. So try and stay away from that accessory branch of the cephalic vein if you can at all. So These two, accessory branch and main cephalic, come together right here. So this vein runs right over the top of her leg. You can see me kind of pushing it out of the way. That's where I'm going to go, right in there. Once you've identified, you want to scrub. Again, I like to use cotton balls, a little less trauma to the skin. And I've got some chlorhexidine scrub and alcohol. And I'm going to clean the site at least 3 times with my scrub and alcohol. Just want to make sure that the skin gets clean. If you need to do it 10 times because it's a really dirty dog, there's nothing wrong with that. I like to have some dry gauze available in case I get a little extra bleeding, kind of keep things clean. So Catherine here is helping out. She's occluding the vein up at the elbow. Got my catheter. I'm going to loosen the seal from the catheter and the stylet there. I like to put my thumb alongside the vein. You can see it kind of bouncing in there. That just helps stabilize. Right in about the center of where I clipped the hair, I'm going to poke. See the vein is moving around a little bit. Just get a nice conservative angle in there. Once I see blood in my stylet, I can go ahead and advance my catheter, squeezing through that skin. Catherine's going to put some pressure over the vein. Careful not to touch where the catheter actually inserts in. I'm going to remove the stylet. Got a T-set here. Make sure I've got a good connection there. Draw back on the T-set. I've got good blood flow, so I know I'm in the vein. Then I'm going to flush. It's flushing easily. I don't see anything blowing up, so this is a good placement. Grab my first piece of tape. Wrap this around the hub of the catheter and around the leg. Want to make sure that your tape doesn't get too tight. See a little bit of swelling. Again, I'm going to make sure that that T-set is well seated. My next piece of tape is going to slide under the hub of the catheter. Again, wrapping around the leg. I'm going to wrap the T-set around the top. One more piece of tape in there. I'm going to flush one more time. Everything's flowing nicely. I'll close off the T-set. Male adapter plug. And this catheter is ready for use. That's it.
So after we get our catheter in, which enables us to administer our induction agents, and we're going to be able to get them to a point where we can intubate our patient. And so endotracheal intubation is obviously a really important step in our surgical preparation. Obviously, this is a great way to ensure a patent airway, which there's a lot, as you see in this picture, a lot of things that can kind of close up over the trachea. And if we have this tube going down into there, it provides us a lot safer way to administer oxygen and to keep them under anesthesia with the inhalant anesthetics that we've talked about. Also, if they're having trouble under anesthesia, again, this is a patent airway that we can use to give them breaths, to give them oxygen, and potentially emergency medications also. A couple things that need to happen before we get to this point, and the reflex that needs to be gone before we can intubate them, which we've talked about, is that swallowing reflex. If they're doing that, we cannot open their mouths barely to get that ET tube down there. And we also need to have that airway open. You can see in the picture between those two arrows, the S is the soft palate, the arrows are those vocal folds, and then the E is the epiglottis, and we need to just slide it right through there. It's a great view. It always looks a little bit different when you're intubating, obviously very much so in smaller animals, cats, dogs, but in general, obviously, the structures are all the same. I want you to think about what stage and plane they are in when we can intubate them. You're going to be watching a video on intubation, hopefully, on the next slide. It gives you a better idea of how to do it, but the best way is to practice. You will need to know the different components of the endotracheal tube. And here's a list here: the hose connector, the body, the cuff indicator, the cuff, and the Murphy eye. We'll be going through those in lab and be sure you understand those. And how to test your cuff, which we'll also be showing you in lab. You're going to blow up our cuff and make sure that it doesn't deflate, as we wouldn't want to be in surgery, intubate an animal, and realize that cuff didn't work. So we always want to test that and make sure that it stays patent before we use that tube to intubate. And if there are any questions, you just get rid of that tube. When you're getting prepared for endotracheal intubation, obviously you want to choose the appropriate tubes for the animal. We want the largest tube that's going to comfortably fit down that trachea. We don't want to put any pressure on that trachea because you can end up with more issues. So you can look at the patient's weight and palpate the trachea, which can give you ideas as to the size of the ET tube. You can also look that the nasal septum width is about the size of the ET tube that you would want. You'll get more as you do this more and more. You'll kind of get a really good feel as to what size tube that you need. But always get a tube ready that's half a size larger and half a size smaller than what you choose, because you may open up that animal, look down in there and say, wow, that's bigger than I thought it was going to be. And so you want that tube that you've tested the cuff and everything's ready to be placed into the animal. You want to be sure that you get all your supplies together just like you did for the catheter. You want to be sure that you have something to secure the tube with, whether you use gauze or the repurposed fluid line. You want sterile lube to put on the very end. Make sure you have a cuff syringe to inflate and deflate that cuff. A laryngoscope or some sort of light source so you can see down in there. You don't want to be scrambling just because you can't see. And I don't recommend mouth speculums. You can really cause damage holding that open like that. So definitely learn to do this with just an assistant and some sort of light source.
So intubation, here we have a tube that we have pre-selected for Richie, our Labrador, and there are a couple of ways of determining the size of the tube for a dog. You can estimate just if you are able to feel the trachea, the big air pipe, and work out roughly what size. Sometimes in some dogs, if you hold their head up and have a look at their nose, there's a fleshy area that sits just down here underneath the nostrils, and that sort of area there can give you a rough idea of the diameter needed for the tube. So Richie, bring your nose back here please, sir, thank you. And so you can see that that's probably around about the same size. A more mathematical way of doing it is getting their weight, dividing their weight by 4, and then adding 4. So he's 30 kilos, that's roughly about, divide by 4, 7.5. If we add 4, that's somewhere between 11 and 12, and we've selected a size 11 tube. So hopefully that will fit. The next thing we have to do is to make sure that he's anaesthetised enough to be able to pass the tube in. So we need him to be in light to medium surgical anaesthesia. So we need to use our ability to judge reflexes to make sure that he's going to be deep enough to get the tube down. Okay, so we'll need our induction agent. Charlotte, our vet nurse, will be holding Richie, and I've got my induction agent Alfaxan here. We already have him with an intravenous catheter in place, and I've calculated his total dose to be about 9 mils. So injecting it fairly rapidly. A big bolus, so it'll go up his vein, through his heart, and then a good percentage of it will go into his brain. He'll be losing his righting reflex, which means that he'll want to fall down. He won't want to sit up. He's a big boy, so we'll have to move him back on the table so we can get his whole body on the table. That's it, good boy. His left-hand side. Now we need to make sure that we're not going to get bitten, so we'll check the palpebral reflex. That's gone. His eye is starting to roll down. I'll check his withdrawal reflex, a good pinch between the toes. That's gone. Excellent. So we can check his jaw tone safely now, just with the tips of our fingers on his incisors so you don't get a big canine tooth chomping through your thumb. He's got some good relaxation in the jaw tone. There is a bit of tension there, but we can probably tube him safely. If he starts chewing a little bit or if it gets tense, we'll have to give him a little bit more. Okay, so Charlotte, if you can please hold his head up and I'll try and show you. He's got a very heavy head. Get his lips up out of the way, if you can do that. And then I'll pull the lower jaw down. We'll use a laryngoscope to make it a little bit easier so that we can actually see what we're looking for. Pull the tongue out straight between the canines. Now, we can see right at the back of his tongue we have the soft palate there. The back of the tongue there. If we pull the soft palate, you can hear him snoring. That's wobbling that pink flesh. That's like a big curtain of pink flesh. If I push that up and back, then you can see the epiglottis. Now, we'll get the laryngoscope in and push this up the base of the tongue and angle it down so that we can bring the epiglottis forward. And just in front of that, we can see the soft palate's fallen back again. So we'll just see if we can push that back out of the way. Soft palate up.
There's too much stuff in the way.
It's tricky. I'll try again. I'll get the
Actually, can we do it without the
laryngoscope.
Or?
I'll try without the laryngoscope. Okay, good. Okay, there we go. So now we've got soft palate up out of the way. Push it out of the way. Epiglottis sitting there. We'll bring that down, forward. And then once we've got that forward, you can see there's the arytenoid cartilages that house and make that little vertical slit, and that's what we're aiming for, to get in. So now we have the tube in place. Tricky, isn't it? Can you see
It's a
that?
big black hole.
Yeah, it's just about to chew me, so.
Yeah.
We're able to swap soon.
So the tube is in place, we can tell it's in place. Sometimes they'll actually cough, and if the tube is clear, you'll sometimes see condensation on the tube as well. That's it. Ah, yes, right. Now we can see. Okay, so we've got the soft palate is up out of the way. That's the epiglottis sitting right there. Okay. Yep. So at the bottom we have the epiglottis, at the top we have the soft palate. Pull the epiglottis down, and then you can see once the tube is in the way, it's hard to see. There's a black hole right there. Into that black hole, and we are in. So the tube is now sitting right in the middle of the arytenoid cartilages. The soft palate is on top,
And we are in.
So one of the most important things to recognize when you're intubating an animal is that you need to know this anatomy. You can't just be jabbing things down there. So don't go into lab without taking some time to look at the pictures and the anatomy. Obviously, it all feels a little different when you're there and you're staring down their throat, but you want to have an idea of what you're looking at. So you really need to understand it. Again, we talked about a couple of slides ago, the vocal folds. Those are the lateral structures on the sides of where you're going to send that ET tube into. The epiglottis is that little triangular flap that covers the glottis, which is the ventral opening to the trachea down into the throat there. So you're going to have to go over that epiglottis, under the soft palate. Sometimes you have to kind of move things around in there depending how open and large everything is, and right into the trachea. Laryngospasms are unfortunately a common complication when you're intubating. We see this, I would say, more often in cats. They're definitely if you touch those tissues right around the larynx there with that ET tube, they're going to become a little sensitive to things going down that throat, and they're going to start to kind of close up over that trachea. And what that is going to, those folds are going to close over the trachea. It makes it very difficult to intubate. And sometimes you have to give it a minute to relax. And then just as soon as they kind of take a breath out, then be ready to put your ET tube right down into there. But the best thing to do is to avoid touching those structures and waiting until you get a good clean direction to intubate down into the trachea. You can put a little 2% lidocaine over those vocal folds so they may become a little less sensitive, just remembering that it can take a few seconds for them to desensitize, for that lidocaine to work. So sometimes I'll put a couple drops and then just close their mouth and kind of take a deep breath and then go ahead and intubate. You can overdose a cat with 2% lidocaine, and it can cause issues. So you just take a teeny tiny amount, and certainly don't do it unless you need to or unless you're supervised. So once you believe that you've intubated, now once you get better at it, you won't have any question whether that ET tube is down the right airway versus the esophagus, right? But there are times where you're doing it really fast, or the patient's kind of waking up and you may not be quite sure. And in cats, and especially when you're first doing this, you want to just move slowly and methodically, but we can check to make sure it's in the right spot. Sometimes they'll cough as you put it down into the trachea, but that doesn't always happen. You can see as they're breathing that there will be some condensation or a little fogging in the endotracheal tube, and that's a good sign that you're in the right place. The air movement, you can put your hand, obviously not occluding the end of the ET tube, but you can feel the air actually coming out of the ET tube. You do need to inflate the cuff first because the air can move around the ET tube if it's not inflated, and you may not feel it even if it is in the trachea. You can try to palpate on smaller animals. You should only feel one tube in the ventral cervical area, so if you're kind of palpating down their neck. And then once you connect them to your circuit, you can see that rebreathing bag moving up and down or in and out depending on the size of your animal. So you always want to recheck when they are attached to the machine, make sure that you're hearing hearing sounds, good lung sounds on each side. Another important thing is obviously we want to get it far enough in that it's all the way into the trachea and it's not going to come out, but we don't want to go too far so that it is all the way into one of the bronchi, because then there'll be a whole other side of the lungs that is not receiving that gas anesthetic, and it certainly won't be as effective and can be a little more dangerous. So you always want to measure before you put the ET tube in, depending on the size of your patient, and make sure that you're going to get it in to the right placement so that you don't have these issues. Okay, so the patient is now intubated. They have been hooked up to whatever monitoring devices that we have available to us, and the anesthetist is keeping track and recording in our medical record all of these values that we're going to keep track of throughout the entire surgery and beyond. So then we have our technicians who are going to start working on getting the animal really prepped for that surgical procedure to start. It doesn't seem like that the hair removal portion of this surgical site preparation is the most important thing, but it is really up there with importance for a few reasons. And one is that this hair preparation that you're going to see is when they go home is what the owners are going to, besides the incision, is what the owners are going to notice about their animal. So we want to be sure to take a lot of care with this. We're going to place the patient in the same position as the surgery that they're in. If you try to do it without doing that, which sometimes we have to, you might not get the same area that is going to be if they're flat. If they're on their side and just lift up a leg, when they're flat on their back, it's going to be a much different area. So you want to make sure that you're shaving the margins that you need to. We talked about in the last slide that they have to be stable anesthetic plane before we start doing this. We don't want to be trying to make sure they're breathing or, you know, that their heart rate's okay and all of this while we're shaving. Obviously, unless it's an emergency situation, we may need to be doing multiple things at the same time, but ultimately we want to make sure we get all those first values written down on our anesthetic log and that they're doing okay, and then we can start shaving. Again, you really want to be neat, you want to be symmetric, you want nice clean lines. This is what the owners are going to see when they go home. Sometimes you have to really look, especially for spays and neuters, you kind of have to look for those incisions because they're on their tummies, but those hair lines is what they're going to notice. We're going to use a number 40 blade for our surgical clip. It's going to get really close to the skin. That is going to make clipping the skin more of a problem. So you want to be sure you're holding the clippers the appropriate way, flat against the patient's skin, so it's actually, it tips your hand a little bit with the blade, and you can kind of pull back on the skin a little bit as you're doing it. I really use two hands when I'm doing it, so you make everything as smooth as possible so you don't clip skin and you don't, and you get as close as you can with that number 40 blade. So when you go to clip, again, you want to be sure to use both hands. That hand not holding the clipper can stretch that skin. That's going to help with ease of hair removal, but it's also going to help prevent that blade from catching on the skin. We always ask how much hair to remove. Obviously, as a surgeon, I always prefer a wider hair removal than a narrow hair removal. But when we're talking spays and neuters, I have much less of an issue with that. So it depends on your surgeon. You need to talk with them. But in general, you can get going that you're going to look at where that surgical site is going to be. So this is why you need to know your surgeries and what the surgeon is going to be doing. And you go 2 clipper blade widths in every direction from that surgical site, at least. And again, it depends on a lot of different factors. With animals with long hair, sometimes we do that clip and then we actually kind of shave off, not down to the skin, but just some of those long hairs that may end up flopping into our surgical site. You can also take when you're doing your surgical scrub is take that, not the scrub, but the alcohol, and kind of flatten them away too. Again, it depends on the animal. Orthopedic procedures, you're going to clip the limb from the joint distal to whatever we're doing to the proximal joint of that surgical incision. Again, it depends on the surgery that we're doing. Talk to your surgeon about it. There are some good clipping guidelines in your textbook. And then once we're done with our clippings, we're going to vacuum up all that excess hair to get away as much of it as we can. Because think of those little hairs around. We don't want those still contaminating our clipped area. This is a picture of a dog prepped for an abdominal surgery. For spays and neuters, it kind of depends. It'll depend on your veterinarian, and we'll teach you. With us, we're going to do it the fullest, but going up, certainly past up to the sternum, really the xiphoid process for some of these, way out laterally, and all the way down to past the pubis. Nice clean cut, always watching the nipples that you don't shave those off. That'll lead to kind of itchy discomfort as they're waking up, and they'll be more prone to lick their surgical area. And the same goes with clipper burns, so you really want to avoid that. This is a prep for some kind of arm surgery. See the shoulder there. Obviously, we're going to, if you have an assistant that can hold up that arm, but see how they're using their left arm to really pull that skin flat so that they can get a close shave with the razors, but it'll be less apt to clip or cause clip the skin or cause clipper burn. For most abdominal surgeries, we want to make sure that urinary bladder is empty. The best way to really do that is to walk the patient before anesthesia. So before you bring them back in to surgery to get them started, before they get their pre-meds even, or right after they get their pre-meds, sometimes is a good time, depending on how the hospital runs, is to take them out for a walk, see if they'll go ahead and go to the bathroom outside. But if they don't do that, or sometimes they don't do it completely, we always want to check their bladder. We may need to manually express it. There are some contraindications to expressing their bladder listed here. A cystotomy, you may not want it fully expressed. It's easier to exteriorize the bladder if you're going to do surgery on it, and you may need some urine in that bladder. Pyometra surgery, because we just want to be very careful in there no matter what. And sometimes abdominal trauma, because we don't want to cause any more issues with what might be traumatic. We also want to take care of this because we don't want them to urinate during the surgery, because that will contaminate the patient. Also can cool them down and cause them to be cold. We don't want urine sitting on their skin, causing urine scald. Certainly contamination of the surgical site itself. And again, if you're going into the abdomen, having that bladder small and out of the way can certainly be helpful. So there are some special considerations with male dogs when we are prepping for abdominal surgery. If it is an abdominal surgery, this is different from a neuter. You do want to remove all the hair from the prepuce so that you can surgically prep that. And then you're going to flush the sheath, because there can be contaminants right around the end of their prepuce into their sheath. So we're going to use a solution, 1 ml iodine with about 9 ml tap water, so really dilute. And you can use a little like curved tip syringe sometimes is the best way, and inject the solution into their sheath and hold the end of the prepuce closed. You can kind of massage it around a little, and then it will come out, and you absorb that with a towel, and you can repeat that a couple times. If you're not going to do that, you can use a sterile towel and clamps, the surgeon or you, depending on what your surgeon wants you to do, and you kind of pull the prepuce off to the side. The veterinarian, the surgeon, can go in laterally to all of that, which we've now kind of clamped off sterilely so it's out of the way. When we begin to think about doing after our clipping, our preparation with our surgical scrub for the procedure that's going to take place, we need to keep in mind that skin cannot be sterilized. So what we're doing is reducing any contamination that could enter our surgical field. And so we need to do this as best we can. We're going to be using antiseptics and rinsing agents for this. The antiseptic portion of our surgical site preparation is really the scrub that we're using to help decrease the contaminants on the skin. There are two generally used in veterinary medicine. The povidone iodine scrub, that's the one that leaves like kind of a browny, orangey color, on your fingers and stuff. It does have a detergent and a pretty wide spectrum activity. Chlorhexidine gluconate, which is when you see it concentrated, has that bluish tinge, has great residual effect, so that will continue to work even after rinsing. The rinsing agents are required to remove the detergent. What we use is 70% isopropyl alcohol. This is going to enhance chlorhexidine's residual activity, how it continues to work even after rinsing. We don't want to use it on open wounds because I think we all know how painful that is. It does, if you have put alcohol on your skin, you know how it can evaporate quickly and it can actually cool that patient. So this is all part when we are preparing and monitoring, that we want to make sure we're keeping our patient warm. If you have a large surface area that you're doing the scrubbing and rinsing agents on, you'll need to pay attention to your how you're keeping your patient warm even more intently. We'll be using a target pattern when we teach you how to scrub in surgery. So you're going to start by placing the gauze in the very center of the incision site, and you work in a clockwise pattern around in a circle, making each circle a little bit bigger, a little bit bigger. You want to overlap as you go, and then so that you don't miss any lines as you're working your way to the outside. Just remembering, as you're touching the outside, you're touching that fur, and you want to be sure to you don't bring that back into the center of your surgical scrub. So you're going to use the scrub in that clockwise pattern, then you're going to use the alcohol swab in the clockwise pattern from the inner circle to the outer circle, and you were going to repeat that for a total of 3 scrubs. This little pattern there doesn't show you exactly how it goes, because you could think of it more as a spiraling from the center outward. You do want to make sure you don't get too much of the scrub, the more soapy stuff on the fur on the outside. That can, or if you do, you just want to be sure to get it cleaned off with alcohol. Dogs especially tend to try to clean that off of them, and anytime we get them licking near our surgery site, we get a little concerned that they're going to get closer and closer to where we don't want them touching.
Right.
y'all not gonna talk for your video?
I'm gonna go back and voiceover.
I don't know how to do all that stuff. I'll just be talking.
Looks like done. Hey, you do want to get the testicles because she's going to push up on them.
Okay.
Even though she's not
That's right.
going to shave it, she will.
All of them? I really am gonna clean that actually.
Go ahead and get another one. You want to make sure as much of that is off as possible. It'll make it itchy.
So I'm going to do this in one.
Just watched a video on a surgical prep for a dog neuter. There are a couple other ones I want to specifically talk to you about. The dog and cat spays and neuters are pretty similar in terms of how we prep them. Obviously, where we clip them and where we specifically scrub are a little different, but in general, they're positioned the same way, just of slightly different areas. The surgical site preparation for an orthopedic surgery is going to be a little different if we're talking about the limbs, and can be a little trickier. Orthopedic surgeries too are ones that we have to pay particular attention to sterility, since getting into these joints and bones can be very dangerous if there is too much contamination. So once you clip the area that you the surgery is going to be focused on, you're going to have pretty wide margins, but obviously if you're working on that stifle, you don't need to shave the entire leg. That's going to cause a lot of discomfort for the animal as that hair is growing back, and obviously very difficult to clip feet if you don't have to. So any hair that is that you don't clip off after your prep, you want to be sure to cover. So here it's covered with tape. You can cover it with gauze, depending on your practice. You just don't want to make it too tight because we don't want to restrict blood flow. So just being very careful that that is going to adhere, but is all it's doing is covering. You're going to make a little stirrup with, and some people use different ways to suspend these limbs, but one common way is to have a little handle that you can hold on to that the end of that limb, so you can hold that limb up and suspend it while you're scrubbing the surgical area and not contaminating anything that bringing any contaminants into your surgical area. Actually lifting that up with some fractures can help realign some of those bones, as long as everything is done really gently. You need to be careful. You're going to start the scrub from the tape and then move proximately, so towards the body. You're going to go circumferentially around the leg. So you're going to make those lines, but or those circles around the leg, starting distally, moving proximally. We're going to repeat this 3 times with scrub before rinsing, which is going to be effective. Again, this differs. The procedure may differ for depending on the hospital that you're working at, and you're going to rinse in the same way. You want to be sure if you lie this limb back down that you're putting it on a clean towel so that you're not reinfecting it. This is just a picture of the limb suspended by the, they've taped and covered the distal portion of the forelimb that probably still has hair on it, but the rest of it is clipped, and they're going to work around to clean this whole area. These are a little difficult. As you can see, there are a lot of crevices and places to kind of go around versus this nice flat abdomen, but certainly it can be done. Another area to talk about kind of separately in terms of how we're going to prepare for it is the perineal region. And there are a couple things that need to be done if we're going to do surgery around the anus or to the anus or any of that area down at the bum. We do want to place a purse string suture in the anus, and what this is going to be doing is to prevent fecal contamination, because obviously the dog is relaxed, and as you've probably seen, they can continue to defecate, especially kind of at the beginning or end of surgery. So a purse string suture is just carefully placed around the anus. It's going to close it up. We definitely want to remove it after surgery, never ever leave those in, and obviously avoiding the anal glands, which are kind of at the 4 and 8 o'clock position. You're going to do 3 separate target patterns. To one side, like to the right of the anus, to the left of the anus, and then lastly around the anus itself. And again, it's going to be in that target pattern, so small circles, and then working your way out in a circular pattern. Unfortunately, complications are not uncommon with surgical site prep, probably clipper burn being the one we see most often. There are definitely a few things you need to do to avoid this, and don't ever think that it is acceptable to have clipper burn, because it is not acceptable. You want to make sure you're using sharp blades. If you think they're getting dull, get a new pair, and you want to be sure that those blades, sometimes you have people come in to clean or sharpen the blades, sometimes you have to send them out. There should be one technician in charge of that. If they have any chipped or missing teeth, before you put those blades to the patient, you want to just take a quick scan of it, make sure nothing looks like it's a problem, and get rid of them if it is. You don't want to push really hard. You shouldn't be pushing really hard. Like I was talking about earlier, and we saw in the one picture, if you're a righty, lots of times you're using that left hand to kind of smooth and push the skin taut, so as you're clipping, it's not getting, the blades are not grabbing the skin. You also, want to be sure that you are angled correctly, that blade is pretty well flat on the skin, so you're going to have a little angle to your hand as you're going against the grain of that fur. Irritation is bad because certainly it can promote infection, and it can cause the animal more discomfort during the healing process than the actual surgical incision, which obviously is unacceptable. So that animal may start licking that area and really create some big problems and lead them closer to causing contamination to that surgical site. Besides clipper burn, we can also have allergic reaction to scrub. More often we see that with iodine solutions. If you note that with an animal, obviously you want to make huge notes in the record that that's the case and never use it on them. It can create these like little red plaques, just irritated looking skin. And again, it depends on how bad it is, if we need to treat it or just let it kind of clean it off and make sure the patient is comfortable, but we definitely want to make sure we don't do that again. So depending on your hospital, oftentimes you do an initial scrub kind of out in the prep area, and then you'll move them into the surgical suite, get them set up for surgery, and then do a final sterile scrub. And this is, again, you want them positioned, set up with all of their monitoring devices before you do that scrub. Then you're going to repeat your target pattern and your scrub with scrub that is just dedicated in the surgical suite. So this scrub has not been out where we've been clipping and where there's lots of activity. It lives in surgery and is just used for this final scrub. After we do that target pattern, again, repeated 3 times with both the scrub, whether it's povidone iodine or the chlorhexidine, and then we're going to rinse it again 3 times. Then we're going to paint a little application of iodine just along where the incision site will be. And we kind of either drip that on, or if you have a spray bottle, you can spray it on. Some hospitals will make you wear gloves while you're doing this final prep, even the earlier prep sometimes. It just depends on what you're doing and what your hospital requires you to do. So we keep talking about getting them into position to do the final scrub and the pre-scrub too. So let's talk a little bit about patient positioning. Obviously, our goals is to include putting them in the best position for ease of the actual surgical procedure. It also is going to be the best way to keep the animal as decontaminated as possible from our aseptic prep of that area. They're going to be in a position where they're not going to move. Obviously, we can't have any movement of them kind of tipping over or legs kind of coming undone or anything like that. And it's also going to give us the best, again, kind of window for doing the procedure at hand. And obviously, all of this depends on what procedure you're doing. We're going to go through in a couple examples, but the top one, obviously, they're going to have an abdominal procedure. The bottom one, that big lump on their back. We're going to be doing mostly abdominal procedures during lab. When we do an abdomen, obviously the best way to get to that abdomen is often in dorsal recumbency, so they're going to be on their backs. The hind legs are going to be pulled straight back. This picture, they're a little bit bent, but we like those straight, and then so that we don't have a lot of pressure or stress to those stifle joints. They're not tied kind of kinked sideways. You can use V-troughs to help stabilize depending on the surgeon, depending on the animal, these really deep-chested dogs, but sometimes we want them up out of the way. They're those metal ones that can be decontaminated and that we can spray and clean. The front limbs can be pulled straight forward, but sometimes it may be helpful to cross them over the chest. You just have to be careful on the animal that you're not inhibiting any respirations by crossing them over the chest. So you want to make sure they have good breathing room and that those legs, which we need to help keep them from tipping over, allow for that. We're going to teach you how to do half hitches. If there's one thing, well, there are a lot of things I want you to come out of this lab knowing how to do, but half hitches are right up there with the rest of it. You're going to do it on each leg, except for the catheter leg, that we're just going to put a simple slip lead over the foot. Sometimes you can do a half hitch right at the paw. It kind of depends. We'll work with you on that. And then we're going to secure those lines to the table with hooks, and again making sure that we can hook them to the table so that we could unhook them really quickly. So you want them to be secure so that you don't come undone, but you don't want to go over and over and over and over and over again. So if there was an emergency and we needed to get this dog sternal really fast, that it would take us 5 minutes to undo all the doing that we did with those ties. So we'll show you how to do that in lab, but be sure you take that really seriously, because learn how to do that. Don't leave school without knowing how to do that well. This is a picture of the half hitch, or the whole leg tied to the table here. You can see up towards the tarsus is where we have the slip lead that's kind of pulling through and getting tighter, and then you do your half hitch around the paw, and then it's tied to the table, but you can see just a couple of loops through. So again, this is something we'll show you in lab, but be sure you learn how to do it. Orthopedic or any kind of extremity surgery will really depend on what's being done and the surgeon that's performing the surgery, but usually there'll be a lateral recumbency, often with the surgical leg. Obviously, the surgical leg is going to be up, not on the bottom, unless you were doing some kind of mass on the medial side of a leg. It might be better to do it the other way. The paw always wrapped, so you can manipulate that leg however you need to. And again, depending for surgical preparation, we're going to hang the limb to prepare all sides of the leg. Think of it as four-sided, and that can again help realign bones. And then the leg will be positioned however needed for surgery. Perianal procedures, they're going to be in ventral recumbency. The same would go true for any spinal surgeries or a lot of spinal surgeries. But for any perianal surgeries, the hind limbs are going to usually hang off the table so that surgeon can get right up close to the anal region without those legs, being stretched out or having to come from the side of the table. Usually it's most comfortable to have the animal propped up, their belly, their back end of their abdomen, kind of over a towel for comfort, getting that butt up in the air a little bit and making it more accessible. Usually you have to tape the tail out of the way and you want to be sure you do that so that it doesn't undo itself during the surgery and come detached. So just make sure that's done securely. The last thing I want to talk about here with our surgical preparation is about keeping patients warm. And really, we have to assume that all of our patients are going to get cold during surgery and that we're going to spend a lot of time combating this. And so just assume this is going to happen. Think ahead, but you really need to think about it if you have small animals, skinny animals, neonates, any of these that are definitely going to lose heat pretty quickly during surgery, but also keeping in mind that this can happen to any patient. During the first 20 minutes of when you put them on gas anesthesia, that is the greatest drop that we see in their temperature. So we want to think ahead, have them prepared, and start warming them up beforehand. It is definitely easier to keep a patient warm by continuing to use these devices than trying to warm up a cold patient. They are going to get cold because we've clipped their fur and we've removed that source of warmth. We're going to scrub their skin. Again, that alcohol is really going to cool them down. Oftentimes we're doing abdominal surgeries. We're going to open up that body cavity. That's going to cool them. You think how warm we usually stay inside and how cool we're going to make it by just putting them in a cold surgery room and opening that up. Those gases that they're inhaling are very cool as they're going in. Some of these drugs are going to prevent animals from shivering and going to slow down their metabolism. So those are other ways that their temperature drops. And lots of times, if we're giving them fluids, which we should be through most of our surgeries, they will maybe start initially warm. Hopefully there's a little kind of incubator for fluids, or you warm them up in different ways. But eventually, unless you have some of those warmers that you can wrap around the fluids, those are going to end up being room temperature, which is much cooler than body temperature. So all of these are reasons and ways that our patients lose body heat, and we want to make sure that we are prepared for it. And we'll talk about that next. So again, you want to get everything ready before surgery, and just think about during surgery that they are going to get cold, so we're going to be ready for it. These circulating warm water blankets are great. There's also forced hot air. It comes in either a blanket or like the picture you see here, it's a little tube you can surround the animal with, and those are going to circulate warm water or warm air so to help keep the patient warm. Heated tables are great. A lot of our surgery tables are heated out there these days, which is really nice. In general, you don't want to place a towel between the table and the patient because that will potentially take away some of the warmth. You just want to always keep an eye on the temperature that you have that table on. Hot water bottles, you've got to be careful with because they can get heated too much. Our patients who are sleeping or are waking up, they cannot move themselves away from things that are too hot. So anything that's too hot could potentially cause burns. We never use electric heating pads for this reason, and there are some horrible stories and pictures out there of burns because of heating pads. Again, we're usually using for animals that are compromised in some way. They can't move off of them, or they may not be able to if it's a larger one, and so we can cause burns that way. So we just don't use those. It's just not a good idea. The hot dog was in the picture previously. We have those at school. You can even, heat up there are other warming devices. Sometimes hospitals will have these discs that you can warm up, just always keeping them at a steady state again before they drop so that we don't lose that body temperature to maintain. And just remembering that this is important, one, for their overall well-being and comfort, but patients that get cold, besides being very dangerous, they actually take a lot longer to wake up, and we want them up and off of anesthesia and moving around as fast as possible. So, all reasons that we need to keep these guys nice and warm. Again, you'll be doing all this surgical prep a lot during lab, and we'll be excited to go through it with you. And this is really important stuff, and it seems simple, and it just seems like, oh, you scrub them and you put a blanket on them. But this is really where the best technicians provide the ultimate in care and comfort and keep their patients safe. So certainly let me know if you have any questions about anything.